COVID-19 vaccination in pregnancy, training for healthcare professionals, working in maternity settings. This module was prepared by the HSE National Immunisation Office. This presentation covers COVID-19 vaccinations and the importance of vaccination in pregnancy, recommendations, safety, and how vaccines work. What is your role as a healthcare professional? Frequently asked questions, making every consultation count and motivational interviewing, vaccinations and pregnancy, additional resources. These are the COVID-19 vaccinations used in pregnancy: Comirnaty, Pfizer-BioNTech, Spikevax Moderna for women 30 years of age and older. Nuvaxovid or Novavax is only used if there is a contraindication or a precaution to an mRNA vaccine. The pregnant woman and the relevant healthcare professional should engage in a shared decision-making process in advance of vaccination. Bivalent mRNA vaccines were introduced to improve coverage against Omicron variants. They are adapted versions of the original Comirnaty and Spikevax vaccines. They have been modified to target Omicron subvariants in addition to the original strain of SARS-CoV-2. The adapted vaccines authorized by the EMA for use in Ireland include Comirnaty Original Omicron BA.1, Spikevax Bivalent Original Omicron BA.1, Comirnaty Original Omicron BA.4/5, and Spikevax Bivalent Original BA.4/5. The National Immunisation Advisory Committee recommend mRNA COVID-19 vaccines remain the preferred option for use in pregnancy. For pregnant adolescents and adults, a COVID-19 booster vaccine is given once in pregnancy if it is more than 6 months since their previous COVID-19 vaccine or infection. COVID-19 vaccines can be given at any stage of pregnancy. The booster is ideally given now between 20 and 34 weeks gestation. If it is more than 12 months since the previous COVID-19 vaccine or infection, administration earlier in the pregnancy should be considered. COVID-19 vaccine can be given at the same time or at any interval with other vaccines recommended in pregnancy, including flu vaccine or pertussis vaccine, Tdap. Why is COVID-19 vaccination important in pregnancy? Well, pregnant women are at similar risk of COVID-19 infection as non-pregnant women. When there are high rates of COVID-19 in the community, this means the risk of infection is high. Pregnant women are at higher risk of severe illness in pregnancy and also in the early postpartum period after giving birth. Pregnant women have higher risk of serious pregnancy-related complications compared to non-pregnant women. Pregnancy is a risk factor for severe COVID-19 infection alone. Healthy young pregnant women with none of the above below risk factors have a significantly increased risk of severe COVID-19 infection. The groups at increased risk include women in their third trimester, 28 weeks or more gestation. Pregnant women from Black, Asian, and ethnic minority backgrounds are more likely than other pregnant women to be admitted to hospital with COVID-19 infection. Risk factors for serious COVID-19 illness in pregnancy include being aged over 35 or older, and having a BMI of 30 or more, or having any of the underlying conditions listed in Table 5A.2 in Chapter 5A of the Immunisation Guidelines. In conclusion, you should target all pregnant women for vaccinations and screen those with COVID-19 infections for comorbidities and risk factors. There are benefits to the baby in the mother being vaccinated. Children under the age of 1 are at high risk of hospitalization and severe illness from COVID-19 infection. Studies have shown that COVID-19 vaccination in pregnancy reduced the risk of stillbirth by up to 15%, reduced the risk of babies being admitted to hospital with COVID-19 in the first 6 months of life. Young babies whose mothers were vaccinated in pregnancy were less likely to need hospital care with COVID-19 infection. Vaccination carries a low risk for the baby in utero or in the mum. mRNA COVID-19 vaccines are not live vaccines, so they cannot infect either a mother or her unborn baby. The vaccine is rapidly broken down in a mother's body. It cannot become part of a mother's or a baby's DNA. Animal studies of the mRNA vaccines did not show any unexpected risk. There is no known plausible biological mechanism which should affect the unborn baby or fertility. COVID-19 infection carries a higher risk for the baby of premature delivery if the mother has severe COVID-19 infection, stillbirth, admission to the neonatal intensive care unit, and the potential of long-term consequences or sequelae from the baby of life-saving care provided or medications administered if the mother was admitted to ICU. If the mother has COVID-19, vertical transmission from mother to baby in the womb is rare. COVID-19 infection in pregnancy has not been shown so far to be associated with increased risk of developmental problems in the baby. It is associated with admission to a neonatal intensive care unit. For the mother, COVID-19 infection carries an increased risk of adverse pregnancy outcomes, included being admitted to hospital, admission to the intensive care unit, delivery of the baby in intensive care, placentitis, postpartum hemorrhage, hypertensive disorders, preeclampsia, even in the asymptomatic cases, cesarean sections in mother with severe disease, and deaths from COVID-19. There's a higher risk if the mother gets COVID-19 infection in the third trimester. COVID-19 infection in pregnancy has an increased risk of miscarriage, and in the Omicron era, pregnant women are less likely to have a preterm birth or maternal critical care admission. Placentitis, what is it? It is an inflammation of the afterbirth or placenta seen in the Delta wave, a rare condition causing fetal distress and stillbirth in a number of women who had COVID-19 infection. It occurs within 7 to 21 days of the COVID-19 infection in the second half of pregnancy, and it's unknown why it happens in some pregnant women. You should advise pregnant women with COVID-19 to tell the hospital to arrange follow-up and to mothers to monitor their movement if they get COVID-19 infection, and attend the maternity unit if they notice any significant reduction in movement. There's no evidence that COVID-19 early in pregnancy is a risk to the baby later on in pregnancy. Initially, we had the Wuhan wild COVID-19 variant virus, and 24.5% of women who contracted the virus early on in the pandemic had moderate to severe infection and symptoms, and this increased in the Alpha wave to 36.2% and further increased in the Delta wave to 42.8% of pregnant women developing symptoms and moderate to severe infection. And in the Omicron era, you can see there is a drop in the rate of symptoms and moderate to severe infection to 14.6%. A study in the UK during the Omicron wave showed that the perinatal outcomes of 3,699 women admitted to hospital with COVID-19. Most women admitted with moderate to severe COVID-19 infection were unvaccinated in this study. The severity of disease decreased with vaccination, and this study highlighted the importance of completing the recommended course. ICU admissions and moderate infections were found to be higher in the unvaccinated and the partially vaccinated, and you will see the details on this study on the right hand of the slide. How do mRNA vaccines work? They are inactivated vaccines. They're not live vaccines. They do not contain any live virus. The vaccine is injected into the deltoid muscle of the arm. mRNA is like a set of instructions to our cells. The mRNA stimulates the muscle cells to produce a protein which is harmless, called a spike protein. The immune system recognizes this spike protein and responds with an antibody production and an immune cell response. There is no interaction with our DNA. The mRNA stays in the cytoplasm of the muscle cell. It doesn't enter the nucleus where our DNA is stored. Antibodies produced by the body cross the placenta and may provide some protection to the baby at birth. The mRNA in the vaccine is broken down in the body within 72 hours, and the vaccine contains no preservatives. There is now a growing body of evidence on the safety and effectiveness of COVID-19 vaccination in both animal and human studies, clearly indicating that the benefit of vaccination outweighs any known or potential risk of COVID-19 vaccination during pregnancy. Vaccines are very closely monitored by multiple agencies, including the World Health Organization, or WHO, the European Medicines Agency, the EMA, the FDA, and the MHRA, the equivalent of the EMA in the UK. Hundreds of thousands of pregnant women vaccinated around the world in the USA, Canada, America, Israel, and there have been no safety concerns identified for them in pregnancy. Professional organizations around the world strongly recommend COVID-19 vaccination in pregnancy, including the World Health Organization, NIAC, and all of the following. Pregnant women were not included in the original clinical trials. However, trials are now taking place in pregnant women. Multiple studies have now been published involving women who were pregnant when they received their COVID-19 vaccine or who became pregnant shortly after vaccination. These studies showed that the COVID-19 vaccines are not associated with an increased risk of miscarriage, stillbirth, small for gestational age, preterm birth, or other adverse pregnancy outcomes. Some examples include a study of 105,446 pregnancies from the Vaccine Safety Database in the USA, reporting that women who experienced a miscarriage were no more likely to have received a COVID-19 vaccine compared with those who did not experience a miscarriage. A registry from Canada included 30,892 women who had received the COVID-19 vaccine in pregnancy, and they found there was no increased risk of stillbirth, preterm birth, small for gestational age, reported in the 3,236 women who gave birth at the time of the study. In terms of safety of the COVID-19 vaccines, over 20 scientific studies in 8 countries in over 250,000 people vaccinated in pregnancy showed that COVID-19 vaccination is not associated with any increased risk of miscarriage, birth defects, stillbirth, growth problems in the baby, preterm birth, or admission to the neonatal intensive care unit. Studies from the UK, Israel, and the US compared pregnancy outcomes among women who received a COVID-19 vaccine in pregnancy and women who did not receive a COVID-19 vaccine in pregnancy. None reported any increased risk of adverse pregnancy outcome in women who received a COVID-19 vaccine. Some of these studies found evidence that vaccination reduced the risk of stillbirth and preterm birth. Miscarriage studies in pregnant women in the USA in 100,000 and 28,000 in Norway showed no increased risk of miscarriage with vaccination. A study in the UK of 180,000 women who received COVID-19 vaccination and pregnancy showed no increased risk of miscarriage, preterm delivery, low birth weight, maternal or neonatal intensive care admission, fetal death, fetal abnormality, or even pulmonary embolus. A study in Scotland in 18,000 women who received the COVID-19 vaccine in pregnancy in Scotland showed no increased risk of stillbirth or preterm birth. And a study of the global COVID pregnancy register included 7,000 women vaccinated during pregnancy and found no increased risk of miscarriage, preterm birth, stillbirth, or admission to the intensive care unit. What are the adverse events for the mother associated with COVID-19 vaccination? The adverse events for the mother are the same as if she was not pregnant. They include injection site pain, fatigue, headache, myalgia and arthralgia, chills, nausea and vomiting, axillary swelling and tenderness, pyrexia, injection site swelling. These are usually mild or moderate in intensity and resolve within a few days after vaccination. For the new adapted vaccines, they have similar side effect profiles to the COVID-19 earlier vaccines. Very rarely, myocarditis or pericarditis can happen as a side effect to vaccination. This happens in up to 1 in 10,000 vaccinated people. It is more common in young men after a second dose and appears to be mild and resolves with conservative treatment, as with myocarditis and pericarditis from other causes. Long-term follow-up of these cases is ongoing. Note, COVID-19 infection is itself associated with myocarditis and pericarditis. There is no association between the mRNA vaccines and clotting disorders, including thrombosis or thrombocytopenia disorder, which are very rare side effects of AstraZeneca or Janssen vaccines, but not these mRNA vaccines. You will find more information in the Immunisation Guidelines for Ireland on the RCPI website. What is your role as a healthcare professional working with pregnant women? You need to make every contact count. Ask and check if vaccinated at every contact, antenatally and postnatally. Healthcare professionals are the most trusted source of information about vaccines. What you say and how you say it makes a difference. Recommend the vaccine. Recommendations by a trusted healthcare professional strongly influence vaccine acceptance. If someone is hesitant about a vaccine, who recommends taking a motivational interviewing approach? This is a patient-centered conversation designed to increase trust in vaccines, increase patient motivation, and increase the likelihood of health behavior uptake. It is similar to making every contact count approach and has been proven to increase vaccine uptake. When you talk about vaccines, most people are undecided and are not anti-vax. They are unsure, have doubts, or are worried. A very small proportion of people are against vaccines or anti-vax. Vaccine hesitancy can be seen on a spectrum, starting with those who refuse all, and they may say, I don't trust vaccines. Or they may be refusing but unsure. I don't think I'll get it. I'm not sure it's safe. They may be somewhere in the middle, accepting some, delay or refuse some. I don't know. I have my doubts. They may be closer to accepting the vaccine and accept but unsure. They may say things like, I think I'll get the vaccine, but I have some questions first. Or they may accept all. I'm ready to get the vaccine. Remember, it is a skilled communication with a healthcare professional that can influence their decision and move them towards getting the vaccine. In motivational interviewing, you ask open-ended questions such as, can I ask you what you're worried about? You need to affirm their strengths. It's good that you're asking questions about the vaccine. It is important to acknowledge and validate their concerns, saying something like, it can be worrying when you read things like that online. Using the skills of reflection and responding, you may say something like, I understand that you want to make the best choice for you and your baby, but that you have some concerns about X. Always ask about vaccines, provide information, and verify their understanding. Address the specific concerns they have and don't bring up new concerns, as this may propagate this. Can I ask what you know about COVID-19 vaccines? Can I provide you with some information based on what you've told me? How are you feeling about the vaccine now you've had a chance to talk about it? Point to other trusted sources of information such as the HSE website or the OCPI website. Remember the positives: the vaccine protects against serious illness. Describe the action. Leave the door open for them to come back. You decided to go ahead and get the vaccine, and you're going to make an appointment with your GP to get it. Or you're going to read the information I gave you and then talk to me about it when you're back next week. Remember to recommend the vaccine for them and their partners. If relevant, tell your own story. I got the vaccine when I was pregnant. Be non-judgmental in your approach. I can see that you feel strongly about this and that you want to do the best for your baby. Always ask permission to discuss the topic. Would it be okay to talk about COVID-19 vaccines? If they agree, offer information, and if they agree, focus on their specific concerns. Can I ask what you are concerned about the vaccine? Do not enter into debate or argument. I can see that you feel strongly about this. Leave space for future discussions. Advise how they can protect themselves. Please know that if you ever want to come back and talk about vaccines, you're welcome to come back. It's really important that you try and protect yourself against COVID-19 as much as you can. And it's difficult to do, but avoiding crowded places and washing your hands. I'm happy to talk to you about it some more if you ever want to talk to me about it again. The goal is to maintain the relationship with the pregnant woman so the door remains open. Remember to adopt a motivational interviewing technique at every consultation. It's good you're asking questions about the vaccine. I know you want to do what's best for you and your baby. It can be worrying when you hear things like that. What are your concerns? What have you heard that worries you? Could I share some information with you based on what you've told me? If they ask questions and say they're worried about the baby, is the vaccine safe? You can use the information below. Although the vaccines are relatively new, they have now been given to millions of people around the world, including hundreds of thousands of pregnant women. The safety of vaccines are very closely monitored for safety in pregnancy by national and international bodies, including the European Medicines Agency, the equivalent, the MHRA in the UK, the CDC, the FDA in the USA, and the World Health Organization. This means that we now have a lot of information about their safety. To date, hundreds of thousands of women worldwide have received a COVID-19 vaccine in pregnancy, and there have been no unexpected pregnancy or infant outcomes seen. There are no safety concerns that we have seen in studies of pregnant women who got the vaccine while pregnant or became pregnant shortly after getting the vaccines. No safety concerns were identified in any of these studies, and there has been no increased risk of miscarriage, no increased risk of congenital malformation or birth defects, no increased risk of stillbirth, no increased risk of growth problems, and no increased risk of preterm birth problems associated with COVID-19 vaccinations. If they ask about fertility, you can tell them the following. the mRNA vaccine and the mRNA that's in the vaccine doesn't go into parts of our cell, the nucleus, where our DNA is kept, so it cannot affect fertility in any way. A number of scientific studies have shown that COVID-19 vaccines do not reduce fertility. The studies have shown that they do not affect ovarian function, egg quality, fertilization, or the number of women who became pregnant. Also, there was a number of women enrolled in clinical trials who became pregnant after getting the vaccine. The number of women who unintentionally became pregnant during the clinical trial was equal among women who received the vaccine and those who did not receive the vaccine. A large number of women have become pregnant since receiving the vaccine. COVID-19 vaccine doesn't affect male fertility. 3 studies have shown that vaccination doesn't impact on sperm quality or sperm count. Can I not protect myself from COVID-19 in other ways? So if they ask this question, this is the answer to give them. Society has opened up now, so it's much easier for the virus to spread and very difficult to avoid being exposed. The Delta variant was highly infectious and the new Omicron variant is even more infectious. And for all these reasons, it means that it's difficult to protect yourself against exposure to the virus. It is important to follow whatever public health advice is available at the time, but the best protection we know now is vaccination. And also important that people around you are vaccinated too. The vaccine helps to protect you against infection if you get it, and against very serious complications for you and your baby. I was vaccinated before pregnancy. Do I really need a booster? Yes, the protection of the vaccine gets weaker over time because if you're pregnant, you are at serious risk of serious illness. It's important for your immunity that you get a booster to get better protection to protect you and the baby. You need 2 doses and a booster in the Omicron variant era. For pregnant and adolescent women, you need a booster once in pregnancy if it is more than 6 months since your last COVID-19 vaccine or infection. COVID-19 vaccines can be given at any stage in pregnancy, and the booster is ideally given between 20 and 34 weeks gestation. You can get it outside of this time period if it's more than 12 months since your previous COVID-19 vaccine or infection. Can I continue to breastfeed? Yes, you can. You can continue to breastfeed. COVID-19 vaccines do not affect breastfeeding, and there's no reason to avoid breastfeeding if you've been vaccinated. You can find more information on our website at www.immunisation.ie on the pregnancy-specific page. There are questions and answers for pregnant women in the OCPI website and a video for communicating with women who are hesitant about vaccines. Guidance from the National Immunisation Advisory Committee is available on the OCPI website, and you'll find training to HSE line training for vaccinators and resources in different languages, including videos. Thank you for listening. This is the end of the presentation.